And we're beginning our recording of the health and healthcare disparities section. If you have any questions, you can always put them you can always put them in the chat box, or you can unmute yourself at the end of each presentation. So welcome all. I'm just going to see if Pedro has made it, but I don't see him unless he's using someone else's computer. Well, why don't we get started with, we'll go out a little out of order just to accommodate the folks who are already on here. I saw Galen Busman earlier. There she is. Hi, welcome.
Thank you.
Yeah, so this is going to be fun. So Tiffany's going to share her screen and put your poster up.
Give me just 1 second. Here's loading.
Oh yeah, no worries. And Galen is poster number 6 and is presenting on disparities in patients who leave without being seen from the UCSF Parnassus ED. Welcome.
Fantastic. Okay to start?
Yeah, you want to go walk us through your presentation?
Absolutely.
Wonderful.
Great to be here. Thanks, everyone. So nationwide, 2% of patients triaged by a hospital's emergency department leave without ever being seen by a provider. And this figure can be as high as 10% depending on the emergency department in question, with higher rates typically seen at under-resourced county hospitals and large teaching institutions in metropolitan areas. These patients represent a population of concern on multiple fronts. The first is that they're at risk for bad outcomes. One of the common assumptions is that patients who leave without being seen have trivial complaints and they are appropriately self-triaging, so we shouldn't worry about them leaving. We know that's not the case. According to various studies, up to 70% of these patients seek further medical attention, 15% return to the emergency department within a week, including patients who require admission or emergency surgery. To the hospital, this is also a driver of patient dissatisfaction, reputational risk, a medical legal risk, and lost revenue stream. And to the Centers for Medicare and Medicaid Services, the percent of patients who leave without being seen is a required reportable quality metric that addresses a hospital's ability to deliver timely and effective care. There are many operational factors that contribute to left without being seen, which is beyond the scope of this presentation, because ED overcrowding and other such factors. But because our question was really, does this phenomenon of patients who leave without being seen differentially impact different groups of patients? Put another way, is there a difference between the population of all patients we see in the ED and the patient population that leaves without being seen? Our analysis was a cross-sectional retrospective review. We considered all patient visits to the emergency department at Parnassus for the past 5 years. To do this, we extracted clinical and demographic data from the electronic medical record that included the patient's race, language, estimated severity index, which is the acuity of a patient's complaint, and the patient's expected payer. A word about where the data comes from: race and ethnicity are selected by the patient upon registration, either at the time of the ED visit or at their first interaction with the UCSF system. Estimated severity index is a scale that measures the acuity of a patient's complaint and is selected by the nurse at triage, ranging from life-threatening, which is a 1, to non-urgent, which is a 5. And notably, one limitation of the data is that due to EMTALA regulations, patient's payer is not collected until the end of the visit. So for patients who leave without being seen, by definition, this was an area where we had a fair amount of missing data. Once we had the data set, we looked at the breakout of all patients by category versus patients who leave without being seen. For example, Black or African American patients represent 16% of all patients, but 21% of patients who leave without being seen. We then looked at the left without being seen rate. This was our key metric that we used in the analysis. For example, 8% of Black or African American patients who come to the ED leave without being seen versus 3% of Asian patients. We used chi-squared tests to compare these differences in the left without being seen rate by the categories that I mentioned earlier: race, ethnicity, language, expected payer, and estimated severity index. Our results, we found that in the past 5 years, 6% of patients who present to the Parnassus ED leave without being seen. By race or ethnicity, Black patients were most likely to leave without being seen versus Hispanic, white, or Latino patients. By language, English-speaking patients were most likely to be seen compared to non-English-speaking patients. By payer, uninsured or unknown patients were most likely to leave without being seen for the reason I explained earlier. But beyond that, for patients where we did have data, Medi-Cal patients were most likely to leave without being seen compared to Medicare and commercially insured patients. While this study is observational, the first thing that came to our mind were potential confounders. Does this data mean anything? We know that our patients who are Black or African American are also more likely to be uninsured or unconnected with primary care services, so they may be presenting with less acute complaints to the ED and more likely to leave without being seen. With that result in mind, we performed a sensitivity analysis to account for potential confounders. We analyzed left without being seen rates by race and ethnicity, controlling for only English-speaking patients, which is most of our patients, excluded the outlier left without being seen categories, so patients who are uninsured or unknown, patients with very high severity complaints who have a 0% chance of leaving without being seen, and patients with very low severity complaints who are more likely to leave without being seen. Within that smaller population, the English-speaking insured patients with mid-severity complaints, we found that Black patients remained more likely to leave without being seen at a rate of 5.4% versus white patients at a rate 4.08%. These results were all statistically significant, both the early results I mentioned by each category and then the compound analysis that we did with those results. Our conclusions, as I mentioned before, this was a descriptive and observational study. Our findings suggest that there are significant demographic differences in patients who leave without being seen from the UCSF ED that may increase the risk of serious health outcomes for patients who do not receive timely emergency care. Our next step is to conduct an expanded multivariate regression analysis to further assess for confounding factors. And the results of this study, we're hoping can inform interventions to reduce left without being seen rates in the UCSF Parnassus ED and disparities in ED care by targeting the highest risk groups. And in conclusion, I'd like to thank my co-author, Hope Schwartz, and my faculty mentors, Dr. Susan Lim and Dr. Elizabeth Horn.
Wonderful, really interesting work. I only have one clarifying question out of curiosity. Did you have any data around time of day or day of the week, given that, you know, the sort of census in the ER can vary quite a bit? Just out of curiosity, maybe you can find that data.
That's a great question. We do have that data. And then the other operational factors that we look at, in addition to time of day, and is the two other factors that compound with that. One is ED boarding, so the number of patients that are in the ED waiting for a hospital bed, and ED staffing, especially nurse staffing, which determines how many beds can be open in the ED at any one time. We narrowed this analysis to really just look at the demographic data, but I think one of the next future directions is to look at how those factors impact wait time, which then impacts the left without being seen rate.
Wonderful. Well, great work. In the interest of time, I will move on to our next presenter, but thank you very much for your presentation. Is Pedro Gallardo here? It's hard to do the gallery. I can't see all the faces.
Yeah, I'm here.
Oh, hi, Pedro. How are you?
Good morning. I'm good.
Good mornings. You'll be presenting on facility level disparities in the delivery of guideline-based treatment across genitourinary cancers. You have about 5 minutes.
Perfect. Thank you. Good morning, everyone. As Dr. Lopez mentioned, I'll be presenting on facility level disparities in treatment of GU cancers. For background, like many other diseases, there have been racial disparities reported in the diagnosis, treatment, and ultimately outcomes of several GU cancers. These disparities are often reported at a national level, which makes it difficult or complicates actually acting upon these disparities to actually result in better outcomes and work towards health equity. And that was kind of what inspired this study. We wanted to see if we could localize disparities to the facility level to hopefully be able to act upon them. So more specifically, this study sought to answer, per race, what proportion of care that patients were receiving was guideline concordant for each genitourinary cancer. And second, were variations in race-based, guideline-based care, were they consistent across GU cancers, or did they vary per malignancy? We specifically looked at patients with clinically localized bladder, prostate, and kidney cancer between 2004 and 2017 using the National Cancer Database. And for each patient, we collected their age, their race and ethnicity, the treatment that they received, as well as the facility that they were treated at. And that was further defined as whether it was an academic medical center or another setting. And guideline-based care was defined according to national care guidelines or cancer guidelines shown in table 1. So for each clinically localized cancer, you can see what constituted guideline concordant care for each different kind of cancer. For our results, there were around 90,000 bladder cancer cases, 73,000 for kidney, and 250,000 prostate cancer cases during this timeline. We found that rates for guideline-based care for bladder cancer were significantly lower than for kidney and prostate. They're around 40% compared to 72 and 77 for prostate, which was surprising. When we divide it further and look at it by race, we find that rates of guideline-based care varied not just by race, but also by malignancy. So as you can see in table 2, rates of guideline-based care for minority patients were significantly lower than for white patients for prostate cancer. For kidney cancer, Hispanic and Asian patients received comparable rates of guideline-based care, whereas Black patients again received significantly lower rates of guideline-based treatment. And then for bladder, Black and Hispanic patients received significantly lower rates of guideline-based care compared to their white counterparts for bladder cancer. We then wanted to see whether there was a correlation in terms of how individual facilities were treating different GU cancers. That is to say, did the same group of urologists, was there consistency in terms of how they treated these different malignancies? We hypothesized that centers with the same group of urologists that were really good at treating according to guidelines for one cancer would translate to another cancer because it's the same group of people at the same facility. We were surprised to find that that wasn't the case. There was very weak correlation in terms of how this same group of physicians was treating different cancers, even at the same facility. The correlation coefficient was 0.1 for prostate kidney, 0.2 for prostate bladder, and 0.3 for bladder and kidney. We restricted it further and just looked at academic medical centers. So these are the centers that are producing the research that informs guidelines. They're oftentimes writing the guidelines themselves. So we predicted that these correlation coefficients would be higher. And they were. They're shown here. The scatter plots are shown here. They were 0.4 for kidney bladder, 0.3 for bladder prostate, and 0.3 for kidney and prostate, which is still weak correlation, even at academic medical centers. Tying it all together, I think this preliminary study shows that, or advances what is already known about racial disparities, and shows that these disparities are not just by cancer type and race, but are occurring even within the same facility. There's significant facility level variation in terms of how these cancers are treated. I think expanding beyond GU cancers, I know there's different diseases presented on today. I think it emphasizes the importance of, when discussing disparities, not just looking at individual patient characteristics such as race, not just looking at single diseases, but rather expanding our analysis to perhaps facility level factors that might be leading to these disparities. And I'll stop there for any questions, but I thank you guys for listening.
Wonderful presentation and quite provocative in terms of the findings, especially even within facility differences. That's by cancer type. That's really interesting. Do you guys have any hypotheses as to why that might be the case, that the urologists are treating differently?
Yeah, so in terms of like next steps, we're currently adjusting our models for different variables, including comorbidities. I don't know if that would entirely explain differences in rates of guideline-based care across minority patients, but that's something that we're kind of doing to dotting our I's and crossing our T's. But otherwise, it's not entirely clear why adherence to guidelines is so much lower for bladder than for kidney and prostate. And I think that warrants further exploration.
Wonderful. Thank you very much for your presentation. And if there are any questions or comments, we guys can put it into the chat. In the interest of time, thank you very much. We're going to move on to the next presentation. Is Jacqueline Lopez here?
Yeah, hi.
Wonderful. You're going to be presenting on risk factors predicting loss to follow-up, hospital admission, and medication non-compliance among patients with infectious keratitis at a public county hospital.
Yeah, sorry, it's a mouthful.
Yeah.
Well, hi everyone. I'm Jackie. I'm a fourth-year medical student. So for a little bit of background, infectious keratitis is essentially infection of the outer layers of the cornea. And it's one of the leading causes of corneal blindness in the world. Treatment it's very intensive, requires hourly antibiotic drop application to the eyes. Unfortunately, systemic antibiotics are not helpful. So it requires this very intensive, antibiotic eye drop administration that really necessitates close follow-up and medication compliance in order to make sure that patients are able to clear the infection. Previous studies looking at patients at county hospitals, I think in Texas, found that patients presenting to county hospitals had worse outcomes compared to patients who were presenting to the nearby private hospital. So some residents and attendings at the clinic here at SFGH were really curious in seeing if they can find risk factors predicting poor outcomes overall, including loss of follow-up, hospital admission, and medication non-compliance here at the clinic at SFGH for patients presenting with infectious keratitis. So in order to study this, we did a retrospective cohort study at the General. We included all patients who had corneal cultures for suspected infectious keratitis in the years 2010 to 2021. And then we excluded patients who had viral keratitis only because that's kind of a different treatment plan. It doesn't necessarily require this hourly antibiotic use. The variables we're looking at, so the social risk factors we included were age, language preference, housing status of the patient, recreational drug use, psychiatric history, and employment status. And then the outcomes that we were looking at included loss to follow-up, which we defined as patients who were missing appointments while still having an active ulcer on their eye. We also looked at medication non-compliance, worsened visual acuity, delayed time to ulcer healing, hospital admission, and then of the patients who were hospitalized, how long they were staying. And we used a logistic regression to look at the impact of these risk factors. So overall, just a highlight of the results. In the risk factors predicting loss to follow-up, unemployment was actually the biggest risk factor found. There were no statistically significant risk factors found for medication non-compliance. There was maybe an association with homelessness, but it wasn't significant. For factors looking at worse final visual acuity, unemployment again came out as the biggest risk factor. For patients who had longer corneal ulcer healing time, age was actually the biggest risk factor found. And looking at risk factors for the likelihood of patients who are hospitalized for corneal ulcer treatment, homelessness, recreational drug use, and unemployment came out as the biggest three risk factors. And then of the patients who were hospitalized, the biggest risk factor for a longer hospital stay was homelessness. In addition to looking at how these risk factors are impacting outcomes, we also stratified patients based on their loss to follow-up status. The charts are kind of small to see on the computer, but essentially there was no difference in the initial and final visual acuity of the patients, and the initial ulcer size was the same. However, patients who were lost to follow-up were more likely to have medication non-compliance issues, which I think intuitively makes sense. Patients who aren't regularly following up at the ophthalmology clinic at SFGH had some sort of issue either being able to get eye drops or not using the eye drops correctly. And additionally, we looked at patients who were hospitalized versus patients who were treated just as outpatients. And it was found that patients who were hospitalized, they had worse visual acuity at initial presentation, and then final presentation, which we defined as when the ulcer had healed. Patients who were hospitalized still had worse visual acuity. And then the initial ulcer size was also larger in patients who were hospitalized, which I think also kind of intuitively makes sense of if a patient has a larger ulcer, has worse vision coming in, they're more likely to require more intensive care, necessitating hospitalization. So overall, kind of like the big risk factors that we found was unemployment, increased age, homelessness, and recreational drug use. I'm not going to go into detail, but there's other studies that kind of looking at how these factors are affecting different ophthalmic conditions. I think some limitations are there was a transition from paper records to the electronic medical record. So some information was lost in the transition to that. So there maybe was some limited analysis for some of these. And then another thing is that this was just done at the general. So it's, county population and urban settings. So it may not necessarily be generalizable to all types of healthcare settings. But I still think overall, I think it was very important to be able to, identify these risk factors. And talking to the attendings at the clinic, they said it confirmed a lot of their kind of intuitions when treating patients with this type of infection. So they said it was nice to actually have the data to now backing up their heightened awareness that they tend to have towards these type of patients. Thank you so much.
Wonderful, wonderful. Such a concerning type of presentation. The eye is very important, and so out of curiosity, now that your team has been able to sort out some of the social factors, could these be patients that get more intensive outpatient follow-up, like navigation, patient navigators, or things like that? Is that something your team has been thinking about?
Yeah, not yet. I think it was first, they just wanted to get the data to see, what, essentially the risk factors were. But I think it's really, I was even thinking about it, kind of what interventions we can take. I think first step would probably be, interviewing everyone in the clinic. I know it's a resident run clinic, so it's super busy. But I think, starting off following up with kind of the providers in that clinic and the staff, seeing what available resources we can give to these patients.
Wonderful. Again, if there are any comments or anything that people want to bring up, you're welcome to put it into the chat box. I'm trying to monitor it, try to do two things at once. But thank you very much for your presentation. Our next presenter is Annalisa Watson, who is presenting on the fear of infertility from using contraception, prevalence and disparities among community college students.
Thank you. Thank you so much, Lenny and Tiffany, for organizing this breakout session. My name's Annalisa. I'm a Master of Public Health graduate student at UC Berkeley School of Public Health. And this past summer, I was fortunate to join a team at Beyond the Pill, which is a program within UCSF's Bixby Center that promotes access and equity in contraceptive healthcare. And today I'm going to be sharing findings from our research on fears that contraception causes infertility among community college students. So fear of infertility from using contraception has been reported in global qualitative research. However, quantitative research describing this fear is quite limited, especially in the United States. And we also know that several meta-analyses of return to fertility after contraception discontinuation have shown that this fear is unwarranted. So our objective was to examine the sphere of infertility by sociodemographic characteristics and examine its association with use of hormonal contraception. So to do this, we analyzed baseline survey data from a randomized controlled trial testing a multi-level intervention with health providers and students regarding contraception education at 29 community college sites in California and in Texas. And these surveys were collected from April 2018 to May 2022 from over 1,800 student participants. And the eligibility criteria included community college students who were ages 18 to 25, assigned female at birth, sexually active, and not desiring pregnancy. And we used multivariate mixed effects logistic regression with cluster robust ears for sight to examine variation in fear of infertility from contraception by these sociodemographic characteristics. And separately, we also modeled hormonal contraception as an outcome to assess its association with fear of infertility. So in total, our biggest takeaway is that 69% of all participants endorsed this following question: I'm worried that birth control will affect my future fertility. And the central bar graph shows that majorities of students across race and ethnicity, first generation college status, and birth control method worried that contraception would affect future fertility, including 77% of Black, 75% of Asian or Pacific Islander, 73% of Latinx, 61% of Native American, other multiracial, as well as 56% of white participants. In addition, 72% of participants who identified as first-generation college students endorsed this fear, as well as 63% of non-first-generation college students. And lastly, we also asked participants what their main method of birth control was, and we grouped them into 3 categories: no birth control, non-hormonal birth control, such as condoms, withdrawal, or copper IUD, as well as hormonal birth control, such as oral contraceptives, IUD, implant, or shot. And among these groups, 79% of participants who did not use birth control, 73% of participants who used a non-hormonal form of birth control, and 61% of participants who used a hormonal birth control endorsed fear of infertility. And so moving to the multivariable model results table, compared to white students, Latinx, Asian or Pacific Islander, and Black students were more likely to endorse fear of infertility. And we also found that first generation students and students who speak a language other than English at home were more likely to endorse fear of infertility than their counterparts. And conversely, students who have children were less likely to endorse fear of infertility than students who did not. And we also found that there's no significant differences between age, receiving public assistance, living in California versus Texas, or receiving sex education from middle, high school, or college. And we also ran an additional model with current use of hormonal contraceptive method as an outcome, and we found that fear of infertility was negatively associated with the use of hormonal contraception. And this finding is aligned with qualitative research that suggests that people do believe that hormonal contraception causes infertility. So ultimately, these results indicate that fear of infertility is prevalent across a diverse range of community college students, and that these participants with fear of infertility are less likely to use hormonal contraception. Fear of infertility from using contraception is ultimately a misperception, and this can be addressed by healthcare providers. However, additional research is needed to understand how exactly fear of infertility influences contraceptive choices, as well as willingness to use contraception. And so that concludes my presentation. Thanks for listening. I'd love to thank my co-authors from UCSF, UT Austin, as well as our partners and training teams and our funders, the JPB Foundation and the William and Flora Hewlett Foundation. Thank you.
Wonderful. Just sort of shocking because I'm not in this field, and I'm like, wow, there's like no association with sex education in school and the findings of this fear of infertility. Do you have any thoughts about that? A hypothesis as to why you think it didn't really matter as much?
Right. That's a great question. Thank you. So I think that sex education covers a lot of different things, but I'm not sure if they're quite getting into like the fertility component. And literature shows that people's knowledge of like ovulatory cycles and things like that are rather low. So I think that's one reason why that was not impactful, but I think that could be its own paper, and it's really interesting. So thanks for noticing.
Yeah, no, and it's an opportunity for these students to be empowered to sort of create sex education that addresses their concerns and their needs. So really good future directions. Congratulations, very interesting project. In the interest of time, the next presenter is Mira Sur, who's presenting on translating a comparative effectiveness study of technologies and health coaching to support behavior change for blood pressure control among Spanish-speaking patients, well, participants.
And thank you so much, Dr. Lopez. Hi, everyone. My name is Mira, and I'm a third-year undergraduate studying public health at UC Berkeley. And then I've also been an undergraduate research apprentice with the hypertension coaching and technology study at Health Research for Action in the UC Berkeley School of Public Health for the past year. And today I'm going to be presenting my poster about how my research team and I translated our studies so Spanish-speaking individuals could participate. So for context, our study is a randomized controlled trial of health coaching versus self-directed technology use to help people with hypertension make healthy lifestyle changes. So participants in Arm 1 receive health coaching from undergraduates like myself, and then participants in Arm 2 are asked to choose a lifestyle area to work on like diet, sleep, exercise, etc. And they're asked to choose an app or website to use to help them with that. And we wanted to translate our study to Spanish because people who speak Spanish are often underrepresented in research. And furthermore, studies show that the prevalence of uncontrolled hypertension is significantly greater for Hispanic adults, and that among Hispanic adults, those who speak Spanish are at a greater risk of hypertension. So for how we did the translations, over an 18-month period, our study instruments, consent forms, and recruitment materials were translated from English to Spanish by proficient Spanish speakers using both forward and backward translation methods. And this means that after materials were translated into Spanish, they were then translated back to English and reviewed for discrepancies by our graduate student researcher and the rest of the team. And then after these materials were translated, our next step was to do community outreach and recruit Spanish-speaking participants. And we did a lot of recruitment by having Spanish-speaking team members go to grocery stores with Spanish flyers, like the one shown on the poster. And then after we recruited Spanish-speaking participants, we screened them for eligibility and randomized them into either Arm 1 or Arm 2. And then they also had to consent to the study and have their baseline blood pressure taken by a team member. And for Arm 1 participants, they were then assigned to one of our Spanish-speaking health coaches who received extra training on how to conduct health coaching in Spanish, in addition to the regular health coach training. And then the results of our efforts were that we were able to screen 18 Spanish-speaking participants for eligibility and enroll a total of 8 in the research study. And our first Spanish-speaking participant has just completed the study, and participants in both arms have expressed gratitude for the health coaching and/or resources provided by the study. And then some challenges we've faced with this translation process are that out of the 34 students on our research team, only 4 speak Spanish. So sometimes it's a little difficult to find students who are able to conduct health coaching and surveys for the Spanish-speaking participants. And then a challenge that I personally have faced is that I'm not a native Spanish speaker. So while I studied Spanish for many years in high school, nobody in my family speaks it, so I wouldn't say that I'm 100% fluent. However, the participants have always been very understanding when I make grammatical mistakes or have to ask them to speak more slowly so I can understand them. So thank you all so much for listening to my presentation. It's just been very fulfilling to be able to work on a project that makes health education and research more accessible to the Spanish-speaking community and will hopefully help to reduce the health disparities that they face. And my team and I were always looking to improve the studies, so we welcome input from any of you whose research also involves translation or training students for lifestyle behavior change in Spanish. And I'd also like to thank all of my colleagues who've mentored me and guided me throughout my time working on this study. And in particular, I'd like to thank our graduate student researcher, Edith Baca. I'd also like to thank our staff research associate, Morgan Vian, and our PI, Dr. Susan Ivy. And last but not least, I'd like to thank our funder, the Jeffrey Thomas Stroke Shield Foundation.
Wonderful, wonderful. Again, if there are any comments or questions, you can put it in the chat or unmute yourself. This is a really big project. I'm very impressed. So just for clarifying, so the Spanish-speaking participants, they're followed for 9 months.
Yes,
And
that's correct.
yeah, and how often do you follow them? Is it multiple times per month or? in terms of behavior change and checking for their blood pressure, or?
So for the participants in ARM 1 who received the health coaching, those of us who are health coaches, we try and call them like every 2 weeks, but sometimes that can vary a little bit, just depending on, when they're available, or sometimes things come up like family things and work things, stuff like that. And then they do have and then in both arms, they have their blood pressure retaken at 6 months and 9 months.
Mhm. Well, that's great. I mean, lifestyle changes are very hard. So this is an intensive type program. Looks really has a lot of potential to make a difference. Any other comments or suggestions from anyone else in the audience before we move on to the next poster? Okay. Well, in the interest of time, thank you very much. I learned a lot. The next presenter is Elizabeth Danielle, presenting on analyzing linguistic disparities in telehealth care outcomes at a multidisciplinary craniofacial center.
Hi, everyone. I'll be talking about telehealth outcomes at our craniofacial center here at UCSF. Telehealth has been widely adopted across many specialties in the wake of the COVID-19 pandemic. However, studies have shown that telehealth exacerbates health disparities stemming from unequal access to technology and limited technological literacy. The UCSF Craniofacial Center has attempted to mitigate these health inequities throughout the adoption of telehealth by providing the following services that included language concordant outreach, assistance with the telehealth platform, and interpreters at virtual appointments. The purpose of this study was to assess linguistic disparities between English and Spanish-speaking patients in access to care, experience, and telehealth attendance at our multidisciplinary craniofacial center. For our methods, we identified all English and Spanish-speaking patients who had in-person or remote telehealth appointments at the UCSF Craniofacial Center between March and December 2020. If a patient did not have access to necessary technology or needed additional assistance logging onto the platform, they were invited to attend an in-person telehealth appointment at the Craniofacial Center. For the non-attendance analysis, patients who did not attend at least one appointment were identified from the chart, and we collected data on the following variables. Next, for the patient-reported outcomes analysis, we performed a phone survey of all patients who did not attend their telehealth appointments to record demographics and assess satisfaction, barriers to care, and understanding of instructions and the provider's role. A member of our team who was bilingual performed these phone surveys using a script. For our statistical analysis, we performed a univariable analysis and adjusted chi-square testing, as well as multivariable analysis with multiple lasso regression. For our results, during the study period, 114 patients did not attend at least one telehealth appointment out of a total of 338 patients. Among these patients, 28.2% of English-speaking patients did not attend a telehealth appointment, and 51.1% of Spanish-speaking patients did not attend a telehealth appointment. Based on our univariable analysis, there were several variables associated with non-attendance, including non-white race and Medicaid insurance and Spanish language preference. However, when we did our multivariable analysis, we found that having Medicaid insurance was the only independent predictor of appointment non-attendance. Patient phone surveys revealed that Spanish-speaking families had 12.4 times greater odds of lacking access to telehealth technology and 10.7 times greater odds of needing help with logging onto the video visit platform compared to English-speaking families. Despite this, there were no significant differences across language groups and families knowing the provider's role in their care, understanding the next steps after their visits, or overall satisfaction with their telehealth visit. So in conclusion, having Medicaid insurance was the only independent predictor of appointment non-attendance. Spanish-speaking patients were more likely to lack access to telehealth technology and need help logging onto their appointment. There were similar satisfaction outcomes among English and Spanish-speaking patients following their telehealth visit in terms of knowing the provider's role, understanding next steps, and overall satisfaction with their telehealth visit. And we think this equity might be due to the following measures already taken by the Craniofacial Center that included providing language concordant instructions, asking patients about their preferred language, explaining how to access the appointment in their preferred language, and utilizing interpreters during the visit. A few things to consider. This analysis was unique because it captured patients who typically lack access to telehealth technology by conducting those in-person telehealth visits. This allowed us to better understand patient satisfaction regardless of technology accessibility issues. Lastly, providers may want to consider utilizing local clinics to conduct remote telehealth visits for patients who lack technology, similar to the Spoken Hub model trialed by the Veterans Health Administration. Thank you.
Well, really, really interesting. So just as a point of clarification, so when the patients came to the clinic, were they trained on how to use the platform or how to engage the platform, or was it all completely remote?
So for the patients that came to clinic, there was somebody, so this was like in the midst of the pandemic
Yes,
where,
yes,
we couldn't,
COVID, yeah.
yes, exactly. And so there was somebody who can help them log on to the computer. They weren't totally like abandoned in the clinic room.
Mhm. Was there, when you did the surveys, was there a preference for using, just regular old telephones as opposed to, more of a visual-based platform?
I'm not sure. I don't think we asked specifically about that. But I think people were pretty sad once if they were able to log on to their video visit, were satisfied with the modality.
Wonderful. Well, really important work, and I think the pandemic really helped us to see, these technology barriers are real issues and can really have long-term consequences for patients and their families. So really important stuff, and I'm glad you were able to share that with us. Any other comments or questions from the audience, either in the chat or if you want to unmute yourself? Okay. Well, wonderful. We have one more presentation. Thank you so much. We have John Yu. I hope I said that correctly. Please correct me. Who's presenting on predictors of extreme hospital length of stay after traumatic brain injury.
Hey there. Yeah. Thanks, Dr. Lopez. Really appreciate it. And thanks for putting this on. This is a really important event for a lot of great research and also for a lot of community awareness. My name is John Yue. I'm a fifth-year neurosurgery resident here at the program, and I was chief resident last year at the county hospital. So this is some of our work that is coming out of our county hospital care for traumatic brain injury. As we all know, a traumatic brain injury, TBI, is a critical health problem and unmet healthcare need. Probably affects 5 to 6 million people in the United States annually, with estimated costs of probably between $80 to $100 billion. And we know that socioeconomic status, race, resources, et cetera, are very important predictors to how people are going to do and who gets better. The rationale for this project and looking at extreme hospital length of stay is that length of stay is essentially a metric for quality of care and for resource utilization, for access to post-acute care, and should be assessed and is assessed. However, there are a number of patients that are known to stay in the hospital for much longer than potentially they need to, or past their date of medical stability. And the reasons for that is unclear and has not been very well studied in the literature. For instance, the average brain injury patient probably stays in the hospital between 4 to 7 days in large data sets. But there are patients that stay in the hospital for weeks and weeks and weeks, and why that is unknown. And a better understanding of that could clarify underlying unmet needs for this population, inform improvements in paradigms of care, and elucidate policy changes, which could improve access to post-acute services. So what we did is we looked at everybody who presented to our hospital within the last 3 years and was admitted to the hospital with a traumatic brain injury. We looked at their entire range of hospital length of stay, and we focused on the top 1 percentile of patients with the most kind of severe or protracted length of stay to get a better understanding of their demographic, socioeconomic, racial, and injury characteristics, and what factors might be at play for why they're staying in the hospital for so long. And here in the results section, we had about 1,600 patients over the last 3 years that were admitted to the hospital with a brain injury. The top 1 percentile, had 18 patients. The mean and median length of stay in the hospital for this entire cohort of 1,600 patients was 8 days and 3 days. And the interquartile range was 2 to 8 days, which is the middle 50%. However, the range was up to 145 days. And the threshold for extreme length of stay or extreme hospital length of stay was set at 70 days in the hospital. These tables are a little bit small, but essentially what we found is that these patients who had extreme length of stay were a little bit younger, 50 versus 60 years old. There's no real differences in their level of homelessness or non-English speaking status. However, 72% versus 31% were of lower socioeconomic status. There were nobody in this extreme cohort that had commercial insurance. 80% of them had Medicaid, which dovetails on very well in the previous talk, and much less of them had Medicare, certainly. They were also more severely injured in terms of their brain injury, about 56% in the extreme cohort versus 11% in the non-extreme cohort. And if you look at where they went on discharge, 22% died versus 8% in the non-extreme cohort. None of these patients went home, and the other 80% had to go to a post-acute care facility, versus 16% in the non-extreme cohort. And when we did a subgroup analysis on everybody who went to a facility, so excluding the patients that were discharged home or went to another hospital, the same associations remained. Lower socioeconomic status by a lot, Medicaid by a lot, 70% versus 20% to 30% essentially. We then drilled down into the 18 people and looked at their medical records very comprehensively to get their characteristics and figure out, what else might be at work here. And what we found is that certainly this is a more severely injured population. 72% of them had an emergent cranial surgery. 33% of them had a surgery to another part of the body. It's qualifying as polytrauma. 4 of these patients died. 3 of them transitioning to comfort measures out of the 4. And we importantly looked at the date of medical stability, which was defined as the first date in the medical record that indicated that the patient was stable for discharge and awaiting discharge. The median date of medical stability was 39 days, and these patients on average stayed an additional 56 days in the hospital after the 39 days before they were placed. The most common barriers to not being able to go to a post-acute care facility was restraints. 71% of these patients required restraints. 30% of them had a safety attendant, and 30% of them were waiting full scope medicated insurance clearance. So what does this all mean? And there's a lot of information here, and obviously, the poster is online, and feel free to contact me with any information, any further questions. But Medicaid is a U.S. federal and state program that covers 73 to 80 million people in the U.S. The qualifications are low household income and assets at 1.3 times the federal poverty limit, which is less than $20,000 for one person, about $30,000 to $34,000 for a family of 3 or 4, which is not very much at all. We see 4,000 patients who have trauma at San Francisco General annually. For 800,000 patients or people in the county, and there's only one skilled nursing facility in San Francisco that accepts Medicaid with 800 beds, usually always at full capacity. We have a little wing in San Francisco General Hospital with 30 beds, which of course is always at capacity as well. And the factors that are preventing these patients from leaving are that Medicaid doesn't reimburse very well. So facilities that accept large numbers of Medicaid patients are more likely to have negative operative margins. The patients who are uninsured at the time of admission often can take 45 days or greater to receive Medicaid coverage, which is a huge barrier. And certain facilities also require patients who are just above the threshold for qualifying for Medicaid to spend down their assets until they're essentially, under the threshold, so they can qualify, which leads to further delays to a population that really doesn't have a lot of resources to begin with. So therefore, there's a critical need for hospitals to invest in programs to both improve insurance acquisition for the underserved and optimize resource utilization to create pipelines for their eventual discharge and placement. Certainly, we saw more deaths in the extreme length of stay cohort than their counterparts, relating to their brain injury severity, polytrauma, poor functional status. And again, these patients were alive on discharge, stayed in almost 60 days after they were medically stable. And the minimal home support, lower resources, Medicaid, severe TBI, this is kind of like a triple threat to being able to get the post-acute and rehab care that you need. A lot of these patients have complex injuries, such as a tracheostomy or a feeding tube. And again, there's only one facility in San Francisco that can accept these people. And also in California, facilities have the right to refuse accepting patients who require safety restraints. And again, this population being more severely injured often requires restraints for their own safety and for the safety of others. So there really needs to be some policy revisions in this regard to not have that as the sole reason for refusal. In any case, there's a ton more work to be done here. We're currently looking into a larger kind of replication studies of this and looking at tiers of hospital length of stay, under the 99th percentile, but certainly prolonged to see if these observations hold up, and working towards kind of informing both hospitals, insurance carriers, and facilities and patients that this is a really big problem. Thank you very much for your time.
Oh, great work. And this is clearly a catastrophic situation for these patients and their families. And we have similar issues here at the VA with the veterans, that there's just very few community beds, even though the VA will pay better than Medicaid rates. There just aren't enough beds for long-term care. So I think there's lots and lots of pockets of this post-acute care chasm that we have here in the Bay Area. So really important work, and definitely we need more policy, more money around these kinds of things. I don't know if there's any comments here. Let's see. All of you have done an amazing work. We're at the hour. I congratulate you all on your research journeys and encourage you to continue your work. Many of you had interesting leads that you're going to follow up on, more analyses, more qualitative interviews, surveys. So lots of wonderful things. I'm glad that you're all in research. This is really wonderful for the next generation. Any other final comments as we close out? I think everyone's excited to be done with their presentation. Congratulations, and we'll see you probably next year in person or in some hybrid version. So enjoy the rest of your day, and thank you.